Hello, everyone, and welcome back to another insightful episode of MedSynapse podcast series, where we bring you the in-depth discussions with experts across various medical fields. Today, we are diving into an extremely crucial topics in orthopedics: infection prevention and management in orthopedic surgery. As many of you may know, infections, particularly after surgery, can lead to serious complications. And with the rise of multi drug resistant organisms, managing these infections have become even more challenging. And to help us explore this, I'm joined by Dr. Shahish Surme, a highly experienced orthopedic surgeon from Navi Mumbai in Maharashtra. Doctor is also well known for his innovative approaches in orthopedic care and his dedication to improving patient outcomes. And we're excited to hear his insights on how infection prevention has evolved and the strategies he employs to keep patients safe before, during, and after surgery. So, welcome, doctor, and thank you for being with us today.
Thank you for the invite. And I'm really eager to talk about a topic that usually gives nightmare to most of the orthopedicians and patients alike. So, very
Yes,
thanks, and let's start.
that's rightly mentioned, well. So now to start off, how have infection prevention protocols and orthopedic surgery evolved over the last decade, particularly with the rise of multi-drug resistant organisms? And are there any game-changing innovations or methods that you find particularly promising?
So, earlier, what used to happen is the orthopedicians used to take a very safe approach towards infections. We used to think of infection control as insurance. So, what is the best available antibiotics in the market used to be given for a very prolonged time? This was not particularly evidence based. So, now that things have developed towards and growing towards evidence based medicine, we have started off using guidelines for medicines. We have also started with something known as antibiotic steroid therapy, which is more like a multidisciplinary approach towards taking care of infected patients, where based on the local epidemiology of infected etiologies and the bugs that are there in these regions and the protocols which are followed in the hospitals, many disciplines get involved in taking care of the patient, which includes infection disease specialist, orthopedician, and also sometimes plastic surgeon and CPTS surgeons, so that the patient is able to get the best care possible for his or her wounds. Apart from that, there are a lot of things that have been game changing. First of all, we are now browsing into the earlier unknown bugs, which are usually causing a lot of infection, especially like non-TB mycobacterium, which is evolving and really not easy to detect even with the current available settings. The next big thing that has happened is the leukoesterase enzyme assays, which are being easily available now. Earlier, we did not have anything which would give us a slight hint of uh, what we say is that we did not have the right kind of instrumentation or diagnostic modality so that we could go ahead and be sure about that whether the infection is present in the joint or not unless we go into the joint. Now with the synovial fluid and leukocyte esterase enzyme assays, we can detect to a very good predictability that the infection is present in the joint or not. And also, arthroscopy is coming into the fray, where arthroscopic biopsies are being used for histological diagnostic measures so that we can go ahead and treat the patient with minimally invasive surgeries.
That is so fascinating to hear about these proactive advancements, I would say. So, on that similar note, as the incidence of resistant pathogens also increases, so what are the latest recommendations for preoperative screening, and how do you optimize patients with comorbidities like diabetes or other immune suppressions to minimize their risk of infections?
Yes, that is a very interesting and very good question, which is the need of the hour. Usually, we think that patient, when ready for surgery, is just a day prior to the surgery. But in fact, the optimization starts on day zero. That is when the patient sees you for the first time in the clinic. You start with a proper history and examination of the patient. And for foremost, you need to educate the patient about his condition and what are his expectations needs to be known by the surgeon. Secondly, what are the conditions the patient is plagued by? We as orthopedicians often forget about the medical conditions that are there in the patient, like diabetes mellitus, which is the epidemic which is growing day by day, and especially in India, which has become the capital of diabetes. So first and foremost, apart from diabetes, we need to look at the general condition of the patient. The nutrition of the patient is very important. Whether he is too obese or less nourished, both needs to be taken care of, and the patient needs to be optimized for that. Apart from that, one thing I need to bring to notice is that the thyroid status of the patient, especially in women over 40 years of age, where if we do not take care of the thyroid properly, the surgery, as you know, is a trauma, can lead to other thyroid related problems also. And thyroid by itself is now known to cause arthritis. So without taking care of the thyroid status of the patient, we will never be able to take care of the patient fully. Other things, especially in male, is the uric acid control that needs to be taken care of. Apart from diabetes, we also need to look at the immune status of the patient. There may be immunodeficient statuses like HIV, it can be hepatitis C, which may be danger to the patient and the surgeon also. And apart from that, autoimmune conditions like rheumatoid arthritis. Special focus on drugs which needs to be stopped is the biological, which needs to be stopped just before the surgery, according to the half-life and not a generalized guideline. Methotrexate, which was earlier stopped by the orthopedician, need not be stopped now and can be taken care of and can be continued throughout the surgery and post-operative period. Another drug I need to focus on is, I think, the sulfasalazine drug, which is known as SARS. It has an aspirin-like action also in it. So the way we stop aspirin 5 days prior to the OT and begin it 3 days after needs to be followed with SARS also. Other drugs, usually the conventional disease-modifying agents, can be continued throughout the surgery, including steroid in low doses.
So it is clear
Apart
that
from that, yes. Apart from that, when we come back to 24 hours prior to the surgery, we can begin with some specific cleaning protocols like using chlorhexidine or betadine to clean the skin. Also, if there is any skin infection which is active or infective focus elsewhere in the body, that needs to be looked into. Especially, it has been found that dental caries, urogenital infections, abdominal infections can lead to joint infections later, especially in cases of replacement, and also in trauma cases, and are responsible for the chronic infections that usually do not appear post-operative but occur after, let's say, more than 3 months. So these things need to be looked into. Nowadays, what is recommended is that for shaving, you need to use electric clippers. You need to clean the site of surgery 1 day prior using a betadine and chlorhexidine scrub. At the time of surgery, you need to plan your surgery very well. What are the equipments you are going to need? Who are the people that are going to be involved in surgery? Because you need as less people involved in the surgery as possible so that the rate of infection itself can be controlled. Also, the setting of the surgery, that is your operation theater. Earlier, we used to say that laminar flow OTs are the best ones, but currently, there are evidences that laminar flow may not be true laminar flow because the turbulence which is created just above the patient and around the surgeons, which might lead to stasis of bacteria rather than them flowing freely into the other direction. So it has become controversial status right now. So depending on the surgeon, you can either use the laminar flow OT or not. But yes, definitely respect the planes which are the surgical planes that you're going to take, proper suturing techniques, proper dressing techniques in post-operatively, and of course, the antibiotic prophylaxis. Earlier, we used to give it 24 hours prior to the surgical incision, but now it is said that it is best to be given 5 minutes before the inflation of tourniquet if you're using one, or at least 1 hour before the incision has been taken. And it can be repeated after 24 hours, not more than that, and not prior. So that's what I would like to do in our pre-operative patient.
thank you for that detailed explanation. And it is so clear that patient's condition before surgery plays a huge role in the outcomes as well. So now also a major challenge that orthopedic surgeons usually face is managing periprosthetic joint infections. So could you share your approach in such cases, and have you ever adopted any novel approaches or emerging technologies that have improved the outcomes?
So periprosthetic joint infections are really a nightmare because a lot of you need to gamble whether to retain the implant or whether not to whether to remove the implant. What is the exact surgery you need to do? How invasive? How conservative you need. So recently there have been guidelines which have been there established, which says that if the infection is occurring less than 4 weeks of the OT or the symptoms of the infections are less than 4 weeks, then it is classified as an acute infection. In cases of fracture, if the fixation is stable, then you can retain the implant if it is less than 4 weeks of duration. Along with that, the best thing you can do is go for a culture sensitivity. If the bug that is involved is susceptible to an oral drug, then that is the best thing that we can have in our armamentarium, because as the bugs become difficult to treat, especially let's say a rifampicin resistant staphylococcus or a fungus, then it gets difficult, and retaining implant may retain the organism also due to biofilm formation. So these three things need to be taken care of. Also, along with that, a plastic surgery reference is very important, because you need to know whether you will be able to achieve a day one closure of the wound that you're going to debride, because the debride needs to be in terms of very famous orthopedic oncological, that is as maximum as possible, so that you get the maximum organisms out of the debride. Secondly, what you need to do is what most orthopedicians do is send a swab from the leaking sample, that is from the sinus. That is not the best sample that you send. If you do not want to go inside and take histological samples, then the best thing you can do is to aspirate the joint. You can aspirate the joint, send the sample for biopsy, or you can, as we say, tissue culture. You can also send for synovial fluid analysis, especially for WBC count, total count, that is differential count, especially for the neutrophils. That if infection is present less than let's say 90 days, then needs to be more than 90, and more than 80 for infection that is more than 90 days. So that is the guidelines which are coming up. Also, you can send for culture and sensitivity. The aspirate is a good sample to be sent and needs to be sent if you do not want to go in and debride. You can start empirical therapy, but not before the samples have been taken. Always take the aspirate or an open sample from the joint, so that you have an idea what kind of bug you're dealing with and what they're sensitive to. Secondly, if you do not have enough sample, if it is a dry tap with the aspirate, then you have to go in. The best way to go in would be using an arthroscope to go in, take the biopsy samples and send them for histology as well as culture. If we find the bug which is there and the infection is more than 4 weeks, and bug which is not susceptible to the regular antibiotics, then you need to remove the implant. Otherwise, what you can do, if the infection is less than 4 weeks, if the implant is stable, not unstable, and the bug is susceptible to the regular antibiotics that you use, especially oral antibiotics, you can retain the implant. That is before DAIR the approach, which is debridement. It should be oncological. There should be antibiotics which are there for at least 6 weeks, taken after a culture sensitivity report and retention of the implant. There are some times what we can do, especially if there is a knee implant which is involved, then you can change the poly of the implant, or you can change the head of the implant if the hip replacement has been done. So this is known as the exchange therapy, which can be done. If the infection is notorious and its duration is more than 4 weeks, then you need to remove the implant. Most of the surgeons today prefer to do it in two stages, where initially the implant is removed, and then later, in the second stage, after placing a spacer for a respectable duration of time, and you get a clearance from the bacteria, you place another implant, which is the replacement. If still the patient is not fit, then you can go ahead with the chronic antibiotic suppression therapy, especially if the implant or fixation implant is stable, and that is, I'm talking about fractures. And if all this fails, then we have to go for something like arthrodesis or excision arthroplasty. And if it still fails, then I'm afraid we have to go for amputation further.
So all the approaches depend on what exactly the different factors is. So a lot of factors come into consideration when choosing different approaches. So now, speaking of intervention, for me, infections can occur weeks or even months after the surgery. So what are the best practices for long-term infection surveillance, and how do you ensure a timely diagnosis and intervention for these delayed or late onset infections?
So most common cause for delayed or late infection is the infective focus, which is not there in the musculoskeletal system. It can be in the oral cavity, the genitourinary system, or the abdomen. So these need to be screened before the surgery is even taken care of. Second thing you need to do is to educate the patient. We have a very small timeline which we need to take care of before we can retain the implant. As earlier as I said, is 4 weeks. Within 4 weeks, if the patient comes to you, it is an ideal time to retain the implant, and the patient can go ahead with just antibiotic therapy and conservative therapy, if needed, debridement also. But it is still less invasive than replacing the implant or placing a spacer in the patient. So patient education is of utmost importance. The patient needs to be told that whenever you get any kind of infection, make sure that you go to the doctor. Don't take it upon yourself as it is done in India. Take care of your comorbid conditions, especially diabetes mellitus, and your immunosuppression conditions like HIV, which usually lead to decreased immunity and increased risk of infection. Infection anywhere in the body can lead to joint infection in already operated patient. So the patient needs to know this prior taking the surgery. Once we know that the patient is infected, we need to tell ourselves that this is not our failure, but something that might happen. It is a natural course that might take place due to infection in other parts of the body. So we need not be conservative about it. The same protocol is followed. If there is a large hematoma or an aspirate or synovial fluid, aspirate it, send it for synovial fluid analysis, do the ESR and CRP of the patient. Once the report comes, look at the double WBC count of the synovial fluid, the neutrophil percentage in the synovial fluid present, look at leukocyte esterase, if possible, the alpha defensive. If these are all present, or if there is a frank sinus vision, then definitely the patient has been infected. Know that, go ahead with debridement, remove as much tissue as required, create clean bleeding planes so that you don't have to come back again. If needed, you can use a vac primarily. No need to do a primary suture at the point of doing the surgery, that's the revision surgery. Retain the implants if it is within 4 weeks of the symptoms that appear. If not, go ahead, put a spacer, use antibiotic cement. You can use local delivery system like calcium sulfate impregnated by antibiotics. Wait for the ESR and CRP to come down and the symptoms of the patient to improve. The best way you can analyze is a smile on the patient's face. If the patient is healthy, he's going to smile, he's going to respond to you, he's going to look well. That is the time you can go for your revision surgery and replacement of pain.
That is rightly mentioned. It is also so incredible to see how much attention actually goes to the details to ensure that long-term patient safety is ensured. Yeah. So now, lastly, infection prevention does not only stops at the operating room. So for patients undergoing joint replacement or complex fractures or repairs, how does your infection prevention strategy extend into the rehabilitation phase?
Rehabilitation phase again you need to look at what exactly is causing the infection in the patient. It is not only orthopedic things that are leading to the infection in the joints. You need to tell the patient to take care of his oral cavity, regular dental checkups, regular health checkups, especially with the physician, so that your diabetes is controlled. In the rehab phase, the patient needs to be mobilized as soon as possible so that the general status of the patient improves. A patient lying on bed is a comorbid patient. He is not able to take care of himself, also leads to psychological problems. So, in fact, a moving patient is an ideal patient that we want. Let's move the patient as fast as possible. Let's educate the patient about what they need to know about their joint, how much they can move, how much they can use it, what is the lifespan of the joint, and what are the precautions, especially related to infection, like if they start seeing a localized temperature at the site of incision, or if they start seeing swelling, they need to report to us as soon as possible so that we know that they have the infection or not. And once we know that there is infection, we can take care of them suitably. But the patient education is very important as far as joints are.
That is rightly mentioned. Patient education and the right kind of information that goes to the patient is also very important. So now, as we wrap today's session, thank you so much, Doctor, for sharing your incredible advices and insights with us.
Thanks to MedSynapse for letting me make my points and contributing to the medical education further. Thank you.
Thank you. And it is clear that infection prevention in orthopedic surgery requires a multifaceted approach from preoperative care to the long-term patient care. So thank you for sharing that.
Thank you. Thank you.
And to our listeners, thank you for tuning into this episode. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until we meet again, stay informed and stay healthy.